Hi, Bob. How are you? You're muted.
Good. How are you?
Yeah, thank you for joining us and doing this.
My pleasure.
Unfortunately, Ash is in Kenya,
Nice.
but we'll record this, provided you have no objection, because Ash specifically asked to record it so he can watch later.
Okay. Well, at least he can't criticize me during the talk. So
Yeah, yeah. So how is New Jersey? You're back to your roots.
yeah, it's nice to be back.
Is it?
Actually, it is. I've had the opportunity to go down to Atlanta several times because I'm still doing some cases down there, and
Oh, really?
nice to check that out. And I don't miss it. I'm where I'm where I'm supposed to be, which is nice to think as I'm going through all the bumps and potholes and literal and figurative as well.
Yeah. I assume they have set things up well for you there. So,
But no, that's my job.
well, yeah, but they've given you the resources to do it, right?
Yes, so far so good. Yeah. But it's always a resource strapped environment. There's no medical centers that are doing well these days, right?
Yeah, it's tough. It's tougher. Yeah. Well, good. We have two neurosurgeons on so far. Bob, do you know Kevin Hines? Have you met?
Yes.
Understood. You know Kevin, and then
How you doing?
And Kaio Matias also.
Hi.
We have more epilepsy surgeons than neurologists sometimes, it seems these days, almost.
Oh, awesome.
And then Chen is doing an SEEG, so he'll watch the uh, the recording afterwards as well. And then Moromi, you see, is on too. I think you know Moromi also. And Moromi, we have people from a bunch of institutions, right? It's not just us, correct? Or
I'm sorry. No, today's not a mid-Atlantic lecture. Today's just for us.
so it's just
Yeah.
us.
So sorry. Yeah. So Jefferson crowd. So yeah, thank you so much for doing this. We really appreciate it. Especially, I'm very appreciative because I have a patient that has 4 leads now, and I'm trying to figure out how to decide when to do what. And I hope to get some insight on that today.
Yeah, I just saw my first 4-lead DBS patient yesterday. The patient got CM and I guess medial pulvinar. And just strategically, we decided I decided we'll turn on the CM first, and then we'll see what happens. And then probably relatively soon, we'll turn on the medial pulvinar. But I guess this is what we wanted to talk to you about.
Yeah. I mean,
work.
I'll be happy. Let's actually let me take some notes here. Yeah, I mean the CM and pulvinar is an interesting combination, which maybe we can discuss the rationale for that as we go along.
Mhm.
Yeah, my patient has anterior nucleus and pulvinar, so it has some anterior, like frontotemporal seizures and clearly occipital seizures. So I think similar to one of your patients in your series number 5 or something. I think we were initially considering a CM/pulvinar electro, but our nurses said no, that's not going to work very well. So we stuck to the pulvinar. So
because of why?
I guess technically that would be difficult, is what I
I'll show one.
understand.
I think we have one in the series, but
Yes.
but I'll show one here.
Yeah.
Although, the thing is, I mean, this is the discussion before the talk, but you have to, some of the combinations make sense and some of them just kind of don't. Like, CM and pulvinar can be done in the same fell swoop, but pulvinar would be for a focal epilepsy and CM is more for a generalized epilepsy. So that they would cohabitate is unusual. So it's not really much of an explanation except for we can do that. And I did do that in one patient. But yeah, it's interesting, the rationale. We'll go over that a bit.
Thanks.
You let me know when you want me to share.
Sure. It's 1 o'clock, and I think you are on nice and early, and the rest of us are here. I think we should start.
Right. It was fun to track down where my presentation is on these 1,000 things I have open, but let's see if that works. Good. See the presentation? Are
All
you?
good.
Yes,
All
yes,
right,
we have it.
let me get rid of some of these floating controls. Okay, well, thank you all for inviting me. This is a fun and interesting topic and one of my favorite ones. I hope to provide some background, our experience, and where I think we stand, what we've learned, and maybe where we're going. Disclosures relative to this presentation would be Boston Scientific, certainly, and Medtronic. Although none of the research that I've done with either one of them have, well, that's not true. Medtronic has supported the ANT trial, and Boston, all the support is not related to this. So first of all, why would we ever consider more than one target? The answer in a word is that the targets we have are good, but they're not great. And we all know the ANT results. The number of patients that are seizure-free is very low. The benefits are reasonable, 65%, 75%, whatever you want to believe, but certainly far from 100%. And of course, until we receive 100% relief on 100% of patients, we can't stop, as well as with no side effects. And so ANT certainly has its limitations. CM we'll go over a little bit later, but we also know that it has its limitations. We don't have a large randomized control trial to tell us about CM. We have retrospective trials, which are all very promising, including my own. I think we end up overestimating benefits in any retrospective trial, and the one prospective trial that we have that's reasonable is the Estelle trial, and what it showed, bottom line, is that the clinical responses were not statistically significant. We saw benefits on EEG, but we're of course looking for clinical responses, and there may be reasons for that that compromise the ability for it to give us a good signal. But bottom line is we still don't have a great established therapy for generalized seizures. And of course, RNS suffers the same limitations because the data is all but identical to ANT-DBS. And the number of patients that are seizure-free, very low, reasonable responder rate, but certainly far from 100% of 100 patients. So neither is great. And that leaves a significant treatment gap for patients that are unresectable and unablatable. So the aims of this are to address whether multinodal same circuit or even different circuit stimulation will improve the results, and will patients that are stimulated in multiple circuits, if and when that is reasonable, improve the results. So we have many nodes in cerebral circuits these days. We're happy to talk about epilepsy being a circuit disorder as if this is some novel concept. And we've always known it was a circuit disorder. We're just putting more teeth into that these days. But the circuits involved in the brain are as complicated, more complicated than the Tokyo subway map. But they certainly leave a lot of room for exploration. You can see some of those favorite targets already depicted on these subcortical and cortical relationships. We know, of course, the first approved stimulation, ANT stimulation, was predicated on the idea of the circuit of Papes. So when we talk about epilepsy being a circuit disorder as if it's a new idea, that was exactly Irving Cooper's idea back in the 1960s. And so he set about stimulating the anterior nucleus of the thalamus, not because he thought seizures arose there, but because they participated in a circuit with other parts of the limbic circuitry. So, and we see any of these hippocampal formation, even mammillary bodies, cingulate gyrus, all of these have been thought about, discussed, and to some extent pursued. So in the lab, back in the last decade, we were interested in this idea of multinodal neuromodulation, and we set about doing this with a novel optochemogenetic vehicle that allowed us to use CTZ, which is the substrate for luminopsin, to do a chemogenetic approach. So this involved an optochemogenetic where CTZ chemogenetically led to light production, and that was coupled to a channel that allowed us to provide inhibition in this case. And we found that combined inhibition of dentate gyrus and ANT markedly reduced the severity and duration of seizures, whereas each alone had a lesser impact. So it supported the idea of multinodal neuromodulation. Had plenty of grant funding, but could never get grant funding for that idea, which probably means it's correct. And there's been some predicate of doing multi-targeting in patients. So this paper published out of Westchester, New York Medical College, 2 years ago, responsive neurostimulation targeting anterior, centromedian, and pulvinar thalamic nuclei, which sounds promising as far as this multinodal idea. But in fact, when you go through their series, you see that these patients had bilateral CM, bilateral ANT, bilateral CM, bilateral pulvinar. Only one patient in their series actually had multinodal stimulation, and that was a right anterior nucleus and a left hippocampus, an interesting combination. And that patient did relatively well. So only one of the 14 patients had a combination of targets. In our own experience with RNS and ANT-DBS, we've had a limited number of patients. I'll go through these one at a time. The first one had bilateral ANT and a left hippocampal RNS. This was a patient that had a previous right ATL. And since I was putting in RNS, I figured we'd go ahead and put an extra electrode in the ANT. We ended up stimulating, like the Westchester patient, in the left anterior and left hippocampus, not crossed. And she did very well. So as to whether it was due to one target or the other is not clear, because we only stimulated both at the same time. Second patient, third patient, and fourth patient are all patients that migrated from one therapy to the other. This first one went from unsuccessful left hippocampal RNS to bilateral ANT, and did fairly well with that change. This patient went from ANT-DBS, which was not working very well, to bilateral hippocampal RNS and had no reduction in seizures whatsoever. And this patient went from bilateral hippocampals to bilateral ANT and had a good result. With both being stimulated, it's a good question, like, do you just shut one off or do you start it again? And no one is ever really going to tell you, oh, these have had no benefit to the first therapy. So you're almost kind of obligated to just add on the therapy, just like adding on a drug. And that's what we did in this case. So not that much experience with RNS and ANT at the same time. So a priori, looking at multinodal, what is some of the rationalization that we have for even looking outside of ANT? So I know that some of us old timers, and maybe some of us new timers, remember the work that was done really beginning with Karen Gale, late Karen Gale from Georgetown, who helped describe the nigral control of epilepsy circuit through her work with defining the area tempestus, a new favorite area, also known as the piriform cortex. And so she described the role of the substantia nigra, pars reticulata, in its projections to the superior colliculus, in fact, and to the cortex, not in what we think about in terms of movement disorders. And that STN having its foot on the gas of the nigra, that you could it's hard to neuromodulate substantia nigra. It's a very large nucleus, but you can get into this choke point at the STN, or even upstream of that if you want, for doing this. Another person that contributed greatly to this work in the preclinical area, of course, is Nico Moshe, who once said to me when I was a resident, basal ganglia, like it was plastics. This is Karen's work. She pharmacologically activated STN, or substantia nigra to activate the nigral control of epilepsy circuit, and showed that it worked in rats and also in non-human primates, and also worked on or Vercule and Durancer worked on electrical stimulation of STN bilaterally. In their case, they were looking at the GARES model, the genetic absence epilepsy rat of Strasbourg, so a generalized seizure model, and they showed also that it was effective. So some predicate for that. In fact, that has been pursued both in STN, I'll review that in a little bit, but also in upstream of that area by Friedhelm Schmidt and his group looking at nucleus accumbens stimulation. And they found that 3 of 4 patients had a greater than 50% reduction with nucleus accumbens stimulation. They did this also with ANT stimulation. They used the Medtronic's double channel. They don't actually ever say that they put in 2 of them, but they must have. They started with nucleus accumbens in each case, and these are their patients, and they saw significant benefits from 3 out of the 4 patients with nucleus accumbens stimulation, and no further improvement in ANT, which does beg the question. We don't know if stimulating at multiple nodes in the same circuit will be effective, or whether multiple nodes in different circuits. So ANT, of course, is PAPE circuit, and nucleus accumbens is the frontal cortical, subcortical, thalamocortical circuits. And I don't have a lot of detail on the nature of those patients in this presentation. So Pulvinar is another area that we think about. It's becoming very popular. Pulvinar is one of the biggest, if not the biggest, thalamic nuclei. So it's got multiple regions to it. So we can't just say pulvinar stimulation, not otherwise specified. The medial region goes into the temporal lobe, and it's the dorsal and lateral region that actually goes to the visual areas. So, and these are not well depicted. You can see pulvinar nicely. You can see some subnuclear imaging characteristics, but we can also use atlases to help us define whether we're going for medial or lateral, and I think it's important to understand that. So there have been 2 papers describing the acute effects of pulvinar stimulation and its beneficial effect on seizures. These are during hippocampal-induced seizures, less severe sort of tonic phase, and improved awareness associated with decrease in global synchrony, and this other paper from Bartolome. And you guys, I'm sure, know about Burdett's paper from Michigan State with 3 patients that they had 90% reduction in 2 patients and 62% in the third, and with 100% responder rate. I invite you to go ahead and look at the imaging of where these electrodes are, and I would submit to you, I had a commentary written up, but I never sent it in, that if you actually look at the nitty-gritty details, I'm suspicious or skeptical that these are really pulvinar stimulated patients as opposed to CM stimulated patients. And, we can dig into that, but this is what we know about pulvinar. So what about in generalized epilepsy? So of course, centromedian we know about, and that's probably the best target that we have at this point, even though we have the limited results from the Estelle trial, where diaries did not have a statistically significant difference, but electrographically we saw that. And this is just important to dig into this just a little bit, because what do we really know about CM? The only thing that's really trackable for all intents and purposes is the generalized tonic-clonic seizures and tonic seizures and drop attacks. And that's what we generally follow. Because it's nearly impossible to follow myoclonic seizures or absence seizures in any sort of a reasonably quantitative manner. And so all of the papers don't track, or none of the papers track, those other seizure types. They only track the major ones. And yet we have patients that come in with complicated absence or with myoclonic seizures that can be disabling. We and others are exploring multi-target neuromodulation for Lennox-Gastaut as part of the NIH-funded UH3 trial through NeuroPace, where we're putting in 2 depth of leads bilaterally into the centromedian nucleus, but also 2 subdural strips bilaterally over the medial prefrontal cortex, and any or all could be stimulated. And we are detecting seizures originating from both. Interestingly enough, we tend to see them earlier in the cortex than in the in CM. And the results of that not yet able to really discuss, but these have bilateral devices, bilateral RNS devices. Surgery is actually pretty well tolerated, and we have very nice targeting that's done through a combination of imaging modalities with Chris Butson and Aaron Warren, who was a critical person in the Estelle trial and then moved over to Boston. So apropos of myoclonus, again, we don't really have good data from CM on myoclonus, but we do have some information on STN in myoclonus. So why would STN even be important in myoclonus? Well, forgetting the NIGO control of epilepsy circuit with respect to limbic seizures, the STN is, of course, a major motor node, which is why we use it for Parkinson's disease, and hence Alan Ben-Benabid and Stefan Charbonez published this paper with Philippe Cahan and Etienne Hirsch a number of years ago, looking at deep brain stimulation of the subthalamic nucleus. They found that STN was performed in 5 patients. These were all a mix of different types of very intractable patients. They saw a 67 to 80% reduction in seizure frequency in 3 patients, with a partial symptomatic epilepsy of the central region. And in one additional patient who suffered from severe myoclonic epilepsy with Dravet, they responded to STN stimulation with a weaker reduction of seizure frequency. So a couple of words. Let me just see where my next slide is. Yeah. Then there have actually been a nice series of 5 patients with STN DBS and progressive myoclonic epilepsy in childhood from Guido Nicas and Jan Vesper's group, and showed a pretty substantial response to those patients. So this shows the difference in targeting that they used with epilepsy, and it's because of this nigra region that they put electrodes down into the nigra, whereas typically we don't play with the nigra in movement disorders. Couple of comments about this. One is that perhaps Mike remembers that when we were starting the ANT trial, actually, that trial belonged to Bob Fisher via an NIH grant before it was funded by Medtronic. So he had an NIH grant to do ANT stimulation, but he could not get Stanford to allow him to do it. They were unwilling to provide the insurance on these patients in case of a complication, and they asked Medtronic to provide that, and Medtronic said, "Well, we're just providing the devices. It's not our trial." And Bob tried to do it with a different PI at a different institution, and Stanford would not allow him to do that either. So they completely blocked his path. Meanwhile, Medtronic was strategizing to do an STN DBS trial for epilepsy. So a number of us had already coalesced a couple of times. And then when Bob Fisher's ANT became orphaned by Stanford, Medtronic decided to pivot and took that trial on instead. So STN stopped at that point as far as something that we're pursuing. I think it's still of interest. My former faculty member, Anna L. Devernius at Emory, who came out of Shepardez and Benabid's shop. She was Benabid's last graduate student. She did her PhD on STN for in a motor seizure model involving penicillin in the motor cortex. So I think there's still some good predicate for the idea and premise for the idea of STN stimulation in motor or even myoclonic seizures. All right, so we have a number of rationales. So how do we go about doing this? And what is the rationale for putting 4 electrodes in and doing this? So one thing is that we actually have this 4-channel device from Boston Scientific, which allows us to put in 4 electrodes. And I would say when it comes to focal seizures, when it's straightforward, when it's mesial, lateral, or polar temporal lobe epilepsy in particular, we didn't go into whether ANT is more effective for temporal lobe versus occipital, parietal, insular, what have you. You guys know from the trial that the trial was not powered to demonstrate a difference between subgroups, and therefore did not see a difference between the subgroups. That doesn't mean there is no difference between the subgroups. And we sometimes when we have absence of information, that's not absence of evidence is not evidence of absence. So it doesn't mean that it's not better in temporal lobe. And sometimes we need to fall back on our premise and what is the robustness of the information supporting it. I think based on the premise of what we think we understand about limbic epilepsy, that ANT should still be preferred for limbic epilepsies. But what about when you have a patient with focal motor or tonic seizures? We could think about that perhaps ANT is not the best target. I'm interested in your experience with this for my own in our center. When we have someone with bad tonic seizures, they generally don't respond very well, especially if they have very strong focal motor seizures originating from central regions. I don't think ANT really has access to that circuit personally. And there we might think about STN or maybe even VIM, which I've never seen implanted. Parietal onset seizures, we do think about pulvinar because of the involvement of pulvinar in the visual circuitry, at least in the dorsal and lateral nuclei, and similarly with occipital seizures. And so when you're approaching this patient and thinking about only putting in 2 electrodes, I would ask the question, which has a higher credence, ANT-DBS, which has been shown to be beneficial for all seizure types, but in this case for non-limbic seizures, versus doing a non-limbic circuit DBS, which has no predicate knowledge for it. So that always puts me on the fence, like I'm going to put in a pulvinar-only stimulation, but I really have almost no data on it. Whereas I know that some patients that might respond to pulvinar were probably in the Sante trial. So I always found myself over the fence on that. And so that's when we started to use the 4-channel Versailles R32 instead of the R16. So we don't have to answer the question. And then we could think about doing various different combinations of targets. And really, all that it costs 2 things. Costs 2 extra leads, costs the risk associated with 2 extra leads, which in the days of stereo EEG, we have to say is minimal, as well as minimal based on our clinical trials. It costs, as you'll see, programming time. And it also costs not being able to have access to the Percept recording of seizures, which I'm sure you guys have gotten very interested in that as well. If not recording of seizures, at least recording of power associated with seizures. So that's one of the things you do give up. So for generalized epilepsy, when it's straightforward, when it's symptomatic generalized epilepsy with drop attacks, I think CM is the best target as far as we know, and I don't see a lot of rationale for doing something else. But what about when they have prominent GTCs? We know that CM is not actually that good for GTCs. It's good for drop attacks, as far as we know. So what about ANT? I'll provide a little bit of information about that, but we know from the Sante trial that ANT stimulation decreased seizure severity on the Liverpool scale, and decreased generalized seizures. And so we don't know that ANT is not beneficial for GTCs. So perhaps we should be thinking about ANT in patients with generalized tonic-clonic seizures. And so again, I asked the question, which has a higher credence for generalized tonic-clonic seizures? CM, which we don't have we only have retrospective data, and the data that we have prospectively is not that great. Is that better for GTCs? We think it doesn't work that well versus ANT-DBS, which actually decreases seizure severity in a randomized controlled clinical trial. I have difficulty answering that question in this scenario, so we can do both. What about patients with prominent myoclonic features? Should we be thinking about STN? Because we have a handful of patients with suggestive data that it's effective, and we don't have any data that CMDBS helps myoclonic epilepsy, because it's not easy to record myoclonic features. So again, which has higher credence for myoclonic seizures? CM, which we use in generalized epilepsies, or STN, which we have very little data on, not enough to just implant STN. So again, do both CM plus STN. And this approach has only been driven even further by, of course, our adoption on this side of the ocean of stereo EEG, and many people are now beginning to ping the circuitry involved, which we always knew was involved, but doing multi-site thalamic recordings at a number of different centers, this just being one of them, and putting those stereo EEG electrodes into those structures. I think we can have a discussion as to what is the premise for doing this on a patient-by-patient basis for a clinical reason versus doing it as part of a research study. I think we could probably spend 2 hours having an ethical discussion about that. I always think about this in terms of exactly how I'm going to use the information on this individual patient to impact their clinical care. When you do it to impact someone else's clinical care, it's research. When you do it to impact that patient's clinical care, it's for their clinical reasons. It is an experiment. And so you might say it's research on that patient, but I would submit to you that everything we do is research, even when we think we know what we're doing clinically. And I wrote a little ethical piece on this. I'll be happy to forward to you at some point if you want. All right, so what is the experience then with multinodal targeting with some of these subcortical structures, non-RNS? So the Mayo group published this nice paper several years ago of 16 patients, 14 with generalized plus focal seizures, and they implanted them with bilateral CM plus bilateral ANT with 2 separate devices. And they saw no difference in seizure reduction or responder rate by adding ANT to CM alone. So CMDBS alone in 5 and added in 6 is a very small data set, but it suggests that it doesn't have any additional benefit to CM in generalized seizures. Maybe that's true and maybe that's not. I will say we had an interesting patient that we're soon to submit a case report on. This patient was actually the very first patient implanted after approval of the device in 2018 by the FDA. I'd been waiting for a while with this patient. Patient actually had primary generalized epilepsy as demonstrated by stereo EEG. We didn't anticipate we were going to see that, but that's exactly what we saw. And I was in a quandary. This device was just approved for targeting the ANT in in focal epilepsy. And what I wanted to do was centromedian in generalized epilepsy. And Medtronic was making a big deal out of this first implant. So it was very clear I couldn't do that. And so I actually thought about doing CM plus ANT with a single device. I wasn't going to put in 2 devices. And I explored whether you can get from ANT to CM. And the answer is you can't without going through the sagittal sinus. You can actually, and I thought about this, you can get from the ANT on one side to the CM on the other side and have crossed electrodes. A, I didn't think that was going to look good. And B, you needed a 20-millimeter expanse of electrodes, and even Boston Scientific can't provide that. So finally, I had to make a decision, and I decided to implant ANT. This patient had mostly tonic seizures and focal to bilateral tonic-clonic seizures, and he did very, very well. So his GTCs responded very quickly and basically disappeared. And he had a progressive improvement in his tonic seizures. And we got to about 90%. And we've actually brought him back in to try to get the rest of his tonic seizures. But then we realized that one of these electrodes, which was implanted posteriorly in this case, had popped out of the ANT. And when I replaced that electrode, he went to 100%. We got very good response from ANT in primary generalized epilepsy with tonic seizures. And we did a literature review, and there's basically is just like one or two patients that we have been able to find in the literature. So ANT could be a good thing to use. We don't really know, along with CM. Cases in which either ANT or CM seem to offer lower odds of having a clinically meaningful response were implanted with both electrodes. So this is our case series, which I think you've read. With ANT plus CM, focal onset. This is the first one, plus multifocal, non-limbic. We did some patients in similar vein, one with LGS-like, but some seizures of focal origin that suggested maybe ANT in addition to CM. We did several patients with pulvinar. Again, I provided the rationale for that. These both had posterior quadrant epilepsies. We actually did a couple of patients with medial dorsal with the idea that it can participate in motor region seizures, but really predicated on subcortical cortical CSEPs that we did that showed some connectivity. And this could be one rationale for putting in subcortical electrodes when you think you will be able to demonstrate at least connectivity between the epileptogenic zone and one of your subcortical targets, which is what we did in this particular case. And we did 3 patients with myoclonic seizures with generalized onset, and 1 patient with SMA seizures with focal onset, looking at STN. First, the feasibility, targeting two nuclei with 1 lead or using 2 leads and being able, you can actually do up to 4 targets bilaterally. For example, if you got 2 targets with each lead, you could get 4 targets on one side. This patient, as part of our multi-target trial, had medial dorsal and pulvinar to CM. Now this patient is he's a curious patient. I'll show that in a second. I want to show here. So electrode 1, in some cases, had 1 target. In most cases, just had 1 target. In this one unique case, case 2, they had ANT plus medial dorsal. And you can see for electrode 2, we generally did CM or pulvinar or STN. In this one unique case, we did CM and pulvinar. You know, I briefly addressed this before we even started talking. What's the rationale for doing that? So this is all of the patients. I'm not going to take the time to go through each one of them, but you can see the different types of seizures that they had. In this number 2, they had atonic typical absence and focal to bilateral tonic-clonic seizures, but also had some focal features with bilateral PVNH. So that was why this patient had a combination of going back up for a second, of ANT, medial dorsal, and centromedian because of this combination of generalized onsets as well as some evidence of focal onsets. And these last several with STN had absence myoclonic, and this patient had SMA type of onsets. So this case example 2 that I talked about had atonic typical absence, focal to bilateral tonic-clonic seizures. She had bilateral PVNHs, and we did stereo EEG. We saw generalized onsets in some seizures, but also some left frontal PVNH to parsopercularis onsets. And we did subcortical cortical evoked potentials to look at whether CM actually, you know, we could talk about this, but you might think, oh, let's just bring them in and trial CM on the seizures. But if you think about how that's going to go down, first you have to identify the onsets of the seizures, then you're going to do stimulation mapping. And then when they're all done, you're going to keep them in the hospital for how long while you trial one of these targets. And you really should have a control because, it's hard enough to, you're not going to get a slam dunk. You're looking for some decrease. And even if you got 100% decrease, you want to know that they're just not seizing at that point because you've reloaded them on their meds. So you really need control periods and how long are you going to do this? So I think it's very unfeasible to look for clinical benefits. So what we were looking for was some sign that we had controllability of the epileptogenic zone by the subcortical target. So we did these SC-SEPs between MD and CM, and we actually found that CM did not have any connectivity to the EZ, but the medial dorsal did. And so that was the basis for putting in a medial dorsal electrode, which of course is easy to do through the A&T. You just continue it down. And so this patient ended up having DBS. I also did radiofrequency ablation of the EZ. That didn't go down too well. And then we proceeded to A&T to DBS of A&T, CM, and medial dorsal. So this is her PVNH and some of the way we explored that with these electrodes. This is the medial dorsal electrode. This is the pulvinar electrode down here, coming in from back over here. Here's our RF ablation, which didn't do anything whatsoever, and that's why we didn't pursue this. In my RF ablation experience, if you don't get a seizure-free interval after you do it, the chances that doing anything further, as long as you did a reasonable Swiss cheese of this, of whatever the EZ, is unlikely to do anything more. She's a highly intact young woman. So this is the spray of electrodes that we did. And again, we came through A&T into medial dorsal, and then came from behind, going into CM through the pulvinar. And after failed stimulation of medial, so how do you go about this? So we decided to stimulate medial dorsal first because we had some indication it might do something. It didn't. We did A&T alone, didn't do anything. We then treated her simultaneously with A&T and CM, and she became a near responder, but really hasn't done particularly great over the long term. So I would say not an overwhelming win from that patient. Patient 5 is one where we did DBS of A&T and pulvinar. And so this patient had multifocal onset through bilateral frontal, temporal, and occipital regions. And so the occipital region was the premise for the pulvinar and the bilateral frontal. And I think that's what you were alluding to, that you have a patient similar to that. And so this patient had pulvinar, and we used a parietal trajectory and implanted contacts along the long axis of it. And here we want to make sure to get that posterior and lateral, or dorsal and lateral part, because that's the part that has the connectivity. So, and you can actually do pulvinar and CM like we did in patient 2, which I'm not showing here. That does require a more, CM is in front of pulvinar. And so, yeah, it is hard. You can't get the medial pulvinar at the same time as you get CM. So if you have a limbic seizure and you're aiming for the medial pulvinar for that reason, yeah, you can't go into CM, nor is there much of a rationale for doing so. But if you're doing a lateral case where you're thinking it's because of parietal onsets or occipital onsets, you can actually easily get into CM. And then that goes under the rubric of why not. You can put it there because it's there and it's on the trajectory, but there's not much of a real premise for doing it. So the results of the patients that were published in our JNS paper were seizure reduction that was actually reasonable, convulsive seizures, reasonable reduction in a number of those patients. 3 patients became responders with monotarget stimulation at the initially chosen target, A&T in one case, pulvinar in cases 3 and 5. And 2 patients failed monostimulation and moved on to simultaneous multi-target stimulation. So multi-target stimulation for our series was really done in the patients that had failed first stimulation. We, except for this ANT medial dorsal, we didn't start. Actually, that one we started with medial dorsal and then ANT, and then moved on to CM. But these patients over here had multi-target stimulation when they failed the first target. Now, which target do you choose first? Pulvinar. We did choose pulvinar in several of them. And the reason was because even though it was a lower credence, we put them in and we wanted to know if they were going to work, honestly. So that's why we did it. And then we would stop there if we got a good benefit. So we really go with the area that, I don't know, honestly, I don't know how to make the call, but, it would just be sort of a shame to put in multi-target and then not use the one we know the least about, because then we'll never learn about it. Now, is that research? Yeah, that I would say that's part of the slippery slope that sometimes we get into, where we're doing some research because we're trying to learn about it, but that's just some of the ethical challenges we face. So some of the surgical challenges of doing this, skin incisions, this can get to be complicated. So you have to think about that. Imaging protocols and the indications for transmit receive head coils differ. If you're putting RNS and DBS, then and it can get to be very difficult to do any imaging on these patients. But mainly there are programming challenges. It's feasible, but it only adds 2 more electrodes and some time to a case, but it's very difficult for you guys and for the patient and the family. Do you program both at the same time? Well, then it's hard to really learn about either of them. But maybe that's the best benefit. But of course, then you're stuck with both of them forevermore until you start to ratchet one down. And, we're comfortable taking off drugs when someone's seizure-free, but we're not necessarily comfortable taking off a stimulation target when someone's not seizure-free. So then do you do them sequentially? And then which do you choose first? I've chosen sequentially, and I've told you why I've chosen one first versus the other. And then how far do you take the target before you start with the second one? Because none of these patients, or few of these patients, become seizure-free. So when have you plateaued when it's time to start the second one? How long does it take? Gotten into a pickle with some patients where it's 6 months down the line and they're saying, well, why haven't you turned the second one on yet? And they're still having seizures. Well, we don't yet. I mean, how long does it take to learn that the first target is effective? I mean, it probably takes a year before we've optimized the first target. So you don't want to start optimizing one target still while turning on a second one. That just muddies the water. So that gets to be a difficult challenge. And then when you start the second one, do you switch to the second target or just add it to the first one? If you just switch to the second target, if you just add it to the first one, then you don't know how this new target, like the pulvinar, let's say, is really benefiting the patient. Can they just fly solo on the second target? And maybe that was the one that was going to make them seizure-free, and they don't really need the first target, and we don't have to worry about changing the battery for that. Second target is usually more experimental. It's not ANT and it's not CM. So how do you learn about it if the first one is on? And how do you disambiguate the effects of time versus adding the second target? I mean, maybe it's just ripening like a fine wine and you think it's the second target. And in our series, only 3 are actually on 2-target stimulation, at least the last time I looked at this last year. And they were the patients that were doing the worst overall. And the reason they had 2-target stimulation is because they were doing badly with the first target. So does 2-target stimulation not work when we're doing it mostly in the patients that have proven themselves to be the worst of the worst? So we really don't have that much information on whether these things are additive or not. And finally, I would say pulvinar does seem to be fairly effective, because in the handful of patients we did and turned that on, they actually had a pretty good effect. So my perspective is that we have 2 targets. One is an unknown mechanism. We don't really still know how ANT works. Proof of that is the fact that we have a recently funded R01 grant to figure out how ANT works. So I was obviously able to argue that we don't know how it works. And I got that through 3 reviewers. And the second target, we know even less about how it works. If we don't even know how A&T works, then how do we know how CM or pulvinar or STN or MD or medial dorsal work? So you're adding two unknown mechanisms together to get a big mishmash. And so results are going to be unpredictable because we don't know how it works. If you're trying to fix a car and you don't know how it works, you're probably going to make it worse rather than make it better. And when we stimulate to begin with, we already have the curse of dimensionality. When you add in amplitude and frequency, and then you add in synchrony, and then you add in different targets, very quickly we have a nearly infinite parameter space. And so how do we reduce the curse of dimensionality by doing data reduction techniques? And so there's clearly a role for machine learning optimization, which we've been pursuing in my group for some time, and possibility of having some network control where we have biomarkers that actually take care of the optimization and target selection, like other engineered systems. They're not necessarily steering all your airplanes or if when we do a robot and do stereo EEG, we don't pick the movements that are being done. And so I would argue that if you're going to proceed with this interesting area, that you need to proceed with your eyes wide open, that it's going to be complicated. The patients need to know it's going to be complicated. Everybody needs to be patient, and we need to try to learn as much as we can all along. So will multinodal stimulation improve results in the same circuit? I'm not sure still. Will multi-circuit stimulation improve results? I'm not sure. So that's really where it stands right now. 1 + 1 does not necessarily equal 2. Sometimes it equals 1. Sometimes it equals 5. We just don't know when they are, and there's still a significant treatment gap for surgically unresectable and ablatable patients, and this is not necessarily going to bring us over any finish line. And with that, I'll thank all the people that worked with this, but in particular, Andrew Yang, who's at BNI right now. And this shows us at the multi-clinic or multi-specialty clinic that we would run once a month, where we would see the most difficult patients that were having difficulty programming them. So invariably, these multi-target patients would be seen by neurology at the same time as me and my fellows and the Medtronic or Boston Scientific reps. Pretty much Andrew was doing most of the work and the neurologist, and I was sitting on my ass, as you can see. But that is the best way to go about this. And with that, I will end my slideshow and happy to have a robust discussion.
Good. Would somebody like to join in first? I don't want to.
Oh, sure. I have some questions. That was really wonderful, really great overview. Thank you so much. A couple of questions. So for the pulvinar cases, where I think one of the cases you mentioned was not medial pulvinar, where are you targeting exactly for like a parietal or posterior quadrant cases?
Right. Yeah. So those are the more dorsal lateral part of the pulvinar, not the medial. Medial is limbic, and you can kind of get through that to the medial pulvinar. You're coming from a more superior approach. We don't really know where to target these things, and but that is based on what we do know about pulvinar anatomy and circuitry. So yeah, those would be more dorsal and lateral.
Okay, thanks.
And there's also a choice of electrodes. So so Boston and Medtronic both have 8 contact electrodes that are 1, 3, 3, 1, spanning 7.5 millimeters. And those might or might not be the ones you want to use. There's almost no rationale for directionality in any of these targets because there's with one exception, there's none that induce side effects that we're managing, except for CM. So CM, you can get motor side effects from and sensory side effects from VC and VIM, and so there you might have a rationale for using the shorter segmented ones. But Boston also makes 8 contact longer lead. And in fact, they're now making 16 contacts that are even longer. So that opens up the possibility, like in the pulvinar, of going all the way medial to lateral, because again, we have to recognize we don't really know. So anything's possible. So I would recommend in most of those cases using the longer spanning 8 contact, or even the new one that's coming out that I think goes like 11 point, no, maybe it goes 15, I think, something like that, millimeters.
Thanks so much.
Short question. The 4-lead DBS, will that be an issue to do imaging with it? Because I heard it might be a bit of an issue.
So probably, you know, when you look at, I'd have to, so for one, there's the leads and then there's the device. If you're just doing Boston Scientific with the 4 leads, we've not had a problem with imaging, with doing post-op imaging. I don't even know that it's covered, like to ask that question in their protocol. So we've not had a problem with it, but it wouldn't surprise me if someone digging into it really deeply found that this was a contraindication. It's not a realistic contraindication, but there's really no concern with that. But it is possible, if you looked at the Boston Scientific cheat sheet for how to image, that might be in there, but I kind of doubt it, since they weren't doing 4 channels until just recently. But you know, it's possible. But you know, what imaging do you need? You need I like to have the MRI, but we really don't need it over and above a volumetric CT co-registered to the MRI. So if you had something you're following that requires repeated MR imaging of the brain, we always get into a slippery slope with that, but you shouldn't be doing this in those types of patients.
Yeah.
Thanks for a great talk. Go ahead, Kyle.
So I mean,
You're muted.
RNS plus the DBS, then definitely going to be an issue, right?
Yeah, that when you couple together anything, VNS, RNS, DBS, VNS, DB, you know, they have almost conflicting and albeit and relatively seemingly silly recommendations, like the RNS one that you can't image for 10 days afterwards. Like, you know, where does that come from? They do manage to almost cancel each other out. So when we've had people with RNS and DBS, or VNS and RNS, it gets to be an imaging problem for sure.
Well, there was a recent paper, I think it was from the French group, that talked about when the medial pulvinar was involved, at least in the hippocampal seizures, limbic seizures, that seizures ended shortly after the sort of pulvinar was invaded by seizures, and the hypothesis then being that maybe pulvinar stimulation, you know, by extension, might help terminate seizures. What do you think of? Does that make sense to you? Is that something worth thinking about?
Yeah.
And again, that goes to ANT and medial pulvinar, but again, if you like, my patient with a CM in the medial pulvinar has a Lennox-Gastaut, but he's also got focal limbic seizures on top of that. It's really a multifocal picture. He has tonic seizures. He's got, you know, complex partial.
Right.
It's the usual mess.
Yeah, I mean, when you start having multiple seizure types that span different circuits, then you can have a justification for CM and pulvinar from time to time, not routinely. I mean, if these are the trees, not the forests.
Right.
Yes, I do think, in fact, actually based on our data from the lab, which is quite different from what you're saying, but we have a paper that'll be coming out somewhat soon, gets through the review process on cortical spreading depression and its role in terminating seizures. And we derived from those studies some suggestion that you might be able to neuromodulate and use cortical spreading depression that was triggered to help terminate seizures. So we actually have a financial disclosure on that. And so, yes, I think it is not unreasonable that there could be a target downstream of of a seizure initiating zone that could participate in termination of the seizures. I don't think that's crazy.
Okay. And when you're doing multiple nuclei, have you'd still do one pair of nuclei first, and you're waiting a while before trying another. You're not doing both at once, right?
Yeah, I am, because you know, I just think about what we're going to get out of it, what we're going to learn. You know, yes, that might be the most effective,
Right.
but we don't know that. Like, if a patient is pressuring you, well, if you put them in, just turn them on. Like, why? It's one of my attendings when I was a resident used to say all the time, it's like Reagan's hammer. You bought it, you own it, now use it. Took me at least a decade to figure out what the hell that meant. It was referring to that $1 million hammer that they bought for like Air Force One or something, or for a fighter that cost $1 million for a hammer. So, all right, you bought it, you own it, you might as well use the damn hammer. You know, patients might say, well, turn on the second one. I had one patient that was really getting pretty antsy about that. But we don't know that doing two-site stimulation is actually going to help them. It could hurt them. I mean, you could posit the opposite scenario, that, you know, you were about to terminate the seizure and then you blasted it off from the second target. So I think we have to recognize that we don't know the answer. And if you're going to get into this, we really want to understand how you respond to one target first, and then figure out how you respond to the second one. Otherwise, you're kind of stuck with 4 electrodes. Let's say you're stimulating them and one of them breaks. And given that there's such a, you know, big variance of seizures from month to month, do you replace that one? You know, I don't know. I just feel it's better to understand one target and then the second. Personal.
And how long do you wait before you decide target 1 is not working as well as I'd like? I'll try target 2.
That's
another problem, right?
Right. It is, because it's an asymptote. You never get there. You know, I mean, you know, with a resection or ablation, the clock starts now. When does the clock start with DBS? It starts when you know, we only turn the clock back. We say, over the last 6 months, did you, you know, so I like to wait. You know, I might say I'll wait 6 months, but then we get 6 months down the line and we're only at 3 volts on the ANT. And so do I pop in the pulvinar at that point when I still have another, you know, well, you know, 2 milliamps to go? And so I try to drag them out as long as possible on the one target before I institute the second target.
Okay.
Just a kind of a similar question. You mentioned some of these early versus late effects as well as the challenge here of the stimulation, like if they build up a neuromodulatory effect. Have you a process for kind of sorting that out, or you, like you said, you just wait as long as you can to see? Because like some of it could be theoretically years afterwards that they're getting benefit.
Right. Yeah, that's right. I mean, like, how long can you wait? You know, I'm not going to make them wait more than a year, I think, with one target. But, and, you know, the way you can sort of drag this out is, of course, seeing them every 3 months instead of every month. So, and you should be, because the variance from month to month is going to be huge. So, but yeah, I think dragging it out as long as possible on one target. But then, you know, some of the patients just have no benefit. You know, they get no benefit, nothing's happening. And of course, the severity of their seizures kicks in. Like, if someone is having drop attacks or someone's having GTCs, and you've been hanging out with one target and you've gotten no benefit, you know, that might even be a medical legal issue. So I think if someone had GTCs and was a SUDEP risk, then I might pull out the stops and just put everything in all at once and figure it out later. So you have to balance that scenario as well.
The other, maybe a technical question, as far as the cosmesis and the patients with the extra wires compared to, say, your 2-lead DBS, have you had any complaints or anything that the patients have been upset about that you've changed?
No, the Boston Scientific, they have a nice low profile connector. So I think the 4 leads is well tolerated based on that. So I've not had a problem with that. It is a bigger device, but there's a rechargeable and a non-rechargeable too. So
do you use the like the Y connector, the 2-to-1
Yes.
connector for the neck? Okay.
You know, my patient Victor, who had the CM and the medial pulvinar, had major difficulty speaking and walking in the first week after implantation, and he's gradually improved. He's only 3 weeks out, I think. I saw him either 2 or 3 weeks out. He's improved a bit, but he still reports, and I saw him, he still seems a little hesitant with his speech. and his walking is not quite as steady. Have you seen anything like that?
So, it's funny,
It's before it's turned on,
I did one here, and I did it with your former fellow Ram Mani. And Ram is, very, very careful and a little bit nervous. And, so of course he talked to me ahead of time about CM. Do you ever have any difficulties after CM? And I said, no, we really haven't had much difficulty. And he said, but he's talked to so-and-so and so-and-so, and they have. And of course, our patient, in the first, 2 weeks or something had difficulty, I think, walking, and was really not responding very well and was tamped down. And so yes, CM can lead to that, I guess, in certain patients. We haven't seen it routinely, but it's described. And whether it's pulvinar, we just don't have enough experience in pulvinar, but we put electrodes, stereo EEG electrodes in these places all the time. Not all the time, but a lot. And we haven't seen much, but I would say probably CM has a history and a risk for certainly temporary effects. We also know it can make you seizure free without turning it on. In some percent of cases, even up to 60% by the Lozano paper years ago.
Bob, thanks for the great talk. We're in the Nautilus trial. I know that Emory was in the Nautilus trial as well. What struck me when we started looking at our patients was the seizure onsets were not, quote unquote, coming from the CM. And you could see the seizure not necessarily in the electrodes that were supposed to be in CM. I'm curious, one, did you see that in your patients in the Nautilus trial? And then two, is that an argument for developing a device where we can actually then record and see ECOG? And how well does the sensing technology that the DBS electrodes have or systems have replace that?
First, actually, we did not participate in the Nautilus trial. We participated in the LGS study. The Nautilus trial, I wonder how you're doing on your budget with that. I mean, we were not going to be able to do that without paying and losing money. And so we said we're not willing to do that. So we didn't participate in that. The LGS patients do have the 2 leads in the frontal cortex, and actually, contrary to my expectation, that's turning out to be pretty important. And we record good seizures in those, and there's certainly it certainly implicates the thalamocortical system. As far as recording, like in Medtronic with Percept, I think that's what you're referring to. Is that what you're referring to?
Yeah, because the reality is, as you pointed out, right? And you were doing some cortical SSCPs to try to understand maybe what target might be better. Is it the CM or the DM, right? As we now have the electrodes in place, in the thalamus and the Nautilus trial, we have 2 patients, and both of them, the seizure, when you see the first activity of seizure, it's actually not in the electrodes that are supposed to be in CM. Now, whether that's a navigation, whether that's reality or not, right? So the question is, does the sensing technology, I guess that's built into the Medtronic device, how well can that replace?
It's not great. No, it's not. We have a paper also at Andrew Yang, who is a Princeton physicist, did a really nice paper and looking at our patients with that. And, you can see changes, but it's very difficult to make them tether to a seizure per se. And of course, we don't have any video, and you're just recording in this one narrow band. But it can be useful as a guide to whether or not you're having a benefit. The decrease in power within that band does correlate with patients who are doing better than patients who are not. But I don't think it'll ever be useful as a closed loop device for neuromodulation like RNS is. But then you could also say, well, RNS is really not a closed loop device. I think that's a pretty cogent argument to be made these days that its responsiveness is irrelevant to its benefits. And I think we're in that place. That doesn't mean that eventually most of us don't hope that there will be a biomarker that can be used as a control function for a closed loop device. I mean, we expended more than one grant on that topic, but I think we're really no closer to having that than when we started. There's always some people working on things that seem promising. So I think hope springs eternal with that. But we're not there. We're certainly with the Medtronic device.
Thank you.
Well, thanks. It's nice you stayed 4 minutes past the end time. I want to be respectful of your time. So thank you very much. We'll have to get you, you're close enough. We'll get you down for grand rounds.
All right, be happy to. I'll just hop on the train. The train, I know where the train station is. It's right near the sign that says Penn Medicine this way.
That's right. It's at Penn. The train station's by Penn. But then you can get on another train and you ride 2 stops and you're at Jefferson.
Right. I didn't see the Jefferson signs up here yet, but I'm waiting. So
It'll happen. Jefferson just merged with Lehigh Valley area, the health system as well.
Oh,
So
yeah?
we're 18
Oh.
hospitals. I think we're going to be 23 or 24.
yeah, that's a big,
Always
that's a
northern
big
Pennsylvania.
air desert sort of over there. So
Yeah.
if you could send me the recording, that'd be great. I love to have these and share them with my residents.
Oh, thanks. Okay, and so Romy will have that, and then Ash and Chen will want to look at it too because they couldn't come.
All right, thanks for having
Thanks a
me.
lot. Take care.
Thank
Bye-bye.
you.
Nice to see you.
Likewise.